I want to consider a common cardiovascular problem called angina pectoris. You can also pronounce that as angina pectoris. The pectoris comes from the word for chest. Angina is Latin for the word for strangle, so that angina pectoris literally means strangling of the chest. And what it involves as far as symptoms are concerned is the patient is going to be having or experience a pressure or tightness of the chest. It may involve chest pain itself. The pain may not only be associated with the chest, but it may be associated with neck or shoulder or arm or upper abdomen. When that happens, that is called referred pain. And medically referred pain has to do with you have some type of offending organ in your body trunk that's irritated, but you feel the pain in response to that irritated organ somewhere else. There is a neurological basis for that, but in medical speak, that is just simply called referred pain. In addition to discomfort of the chest or chest pain or referred pain, the patient may have dyspnea or shortness of breath. They may experience sweating. They may experience nausea. None of these are necessarily present, but it wouldn't be uncommon for them to be present. The bottom line is when the patient is having angina pectoris, what is going on is that you're having a metabolic demand of the heart that is exceeding its own blood supply. As you know from every organ system you've looked at, you have a metabolism going on in the organ system, and then you have the blood supply that is going to be supplying its oxygen and its glucose. But if the metabolism of the organ is exceeding the oxygen and glucose supply, then you're going to have a problem. And that's essentially what we have here with angina pectoris, is the heart is working beyond its own blood supply. And the question is, what's going on with that? Well, the heart has to have its own blood supply through what is called coronary vessels. So as you know, when oxygenated blood is coming from the lung and going into the left atrium and then drops into the left ventricle, and then the left ventricle is contracted and is pumped into the arch of the aorta, that oxygenated blood in the lumen of the atria and the ventricles is not going to be of much help or any help in terms of delivering oxygen and glucose to that tissue itself. That blood in the lumen of the chambers of the heart are just passing through. So as the left ventricle contracts, pushes the bolus of blood into the aorta, at the base of the aorta, just above the aortic arch, the aortic valve, you have a right and left coronary artery that loops back around and will feed the heart its own blood supply. So you have a right coronary artery, left coronary artery, and then they're going to branch off into other named arteries, and we're going to learn some of those names in a later lecture. But every time the left ventricle contracts, it literally is pushing blood into the coronary artery so that it can feed itself. So the problem becomes if you have something that is compromising that coronary blood flow, restricting it, then you're going to be creating myocardial ischemia, again, a shortening of the blood supply to the tissue itself. Now, why would that happen? Lots of reasons for that. One could be that the patient is having some plaque build up in there. So as you know from other studies, the plaque builds up beneath the endothelium of the blood vessel, and the plaque buildup is going to be tied to cholesterol and other biochemical processes, and as that plaque builds up, pushes into the lumen, reducing the radius, therefore increasing the resistance and making it harder for blood to flow through the coronary arteries. You could also have a rupturing of the plaque, such that the plaque content punch through the endothelial layer, and then when that happens and you have little pieces of plaque breaking off, then that's going to create a blood clot, and so now you have coronary thromboses around, again lodging in the coronary arteries, causing great compromise of blood flow there. Or you could have arterial spasms, those smooth muscles in those coronary arteries just contract for whatever reason, again, decreasing the radius, increasing the resistance, leading to compromised blood flow to the heart tissue. So lots of ways of getting there. You have two basic classes of angina. You have stable angina and you have unstable angina. Stable angina is also known commonly as effort angina, and the name is very descriptive because with effort angina or stable angina, the patient, while they're at rest, they're fine. No discomfort, no pain, no anything, everything is good. But when they get up and try to exert themselves, maybe they're climbing the stairs, maybe they're mowing the grass, whatever, then all of a sudden they have that tightness of chest or the pains or shortness of breath or whatever, but it's tied to exertion. So at that time, what they're doing is they're asking the heart to go beyond the blood supply. Typically in stable angina, if you sit back down, calm down, rest, then the pain goes away after a few minutes. Another cause for stable angina, not a cause for stable angina, the cause for stable angina is compromised blood flow, but something that could bring about stable angina would be some type of emotional distress, because if you're dealing with emotional distress, that can be a sympathetic thing, and so you're stressed emotionally, the sympathetic signal goes up, increasing the sympathetic tone to the heart now beats more rapidly, more forcefully, and then again, it's going beyond its metabolism is going beyond the blood supply. So emotional stress could also bring about an attack of stable angina. Unstable angina is a form of acute coronary syndrome, or known in medical speak as ACS. There are different kinds of ACS, okay? There are different types of ACS. And so what I'm saying is that unstable angina is one type of ACS. The symptoms here basically involves that the patient, even at rest, is experiencing discomfort, tightness of chest, or whatever. So it's not really tied to exertion. They can be very calm and still or struggling with this. And I think kind of the standard is you have those attacks or those periods of discomfort have to last more than 10 minutes. And you may be uncomfortable for 10, 15, 20, 30 minutes. Then it goes away, and then it comes back, then it goes away. So that would be kind of a classic unstable angina, but doesn't have much to do with effort because you can be calm, cool, collected, and still have that. This is more serious than the stable angina, and many times the unstable angina could be a predictor for a future heart attack, and of course heart attack is defined as having a myocardial infarction. So this is something pretty serious and needs to be treated. Now there are a number of ways that you can work with someone that is struggling with angina pectoris. Clopidogrel is going to be one drug that is considered an anticoagulant. You've seen the commercials on TV. They call it Plavix. And again, why would you want that? Well, if somebody has angina pectoris and they're throwing off blood clots, then that may be one of the causes for that. You want to make sure that the patient is not throwing clots off to make this situation worse, and so you'd want to put them on an anticoagulant. Another type of drug would be statins, and I'm pretty sure you're familiar with statins, but statins is going to be basically a cholesterol drug to lower the level of cholesterol. If you lower the level of cholesterol, it really can help in terms of impeding plaque formation. All kinds of statins out there. Another approach would be nitrates. And again, I'm sure you're familiar with this, nitroglycerin. Nitroglycerin, typically you'll put it under your tongue, sublingual, and it's pretty rapid, and it will cause an increase in nitric oxide. And nitric oxide is a pretty potent vasodilator, so it's going to dilate blood vessels. And if it's dilating blood vessels, that means it's going to dilate or vasodilate coronary arteries as well. Again, has side effects. If it's dilating your blood vessels, then you're probably going to be having a blood pressure drop, lightheadedness, etc. But if you're dealing with angina pectoris and you're bringing on, and you have the tightness of chest or the pain, you pop a nitroglycerin pill, and that can dilate those arteries to where now you're getting adequate blood supply to the heart pretty quickly, and it will resolve your discomfort. Another class of drugs would be calcium channel blockers. Calcium channel blockers would also dilate or vasodilate blood vessels, which would include, of course, coronary arteries as well. And so you could put your patient on calcium channel blockers. Another drug of choice would be beta blockers, and the beta blockers are going to be blocking the effect of catecholamines, and in this case, catecholamines meaning epinephrine and norepinephrine. And so if you're on a beta blocker, that means, again, with the norepinephrine or epinephrine influence on the heart, if you're blocking that, then that's going to slow the heart rate and it's going to lower blood pressure. And it is also going to be keeping the sympathetic tone from causing the heart to beat more forcefully. So I just kind of want to take a step back and kind of dwell on that, because I'm about to talk about beta blockers in a minute anyway in more detail. But if you have the problem of your metabolic or metabolism of the heart going beyond its blood supply, particularly in the context of beta blockers, if you put the patient on the beta blocker, again, blocking beta adrenergic receptors, that then is going to keep the sympathetics from overstimulating the heart. Because again, if you exert yourself, increased sympathetic tone causes the heart to beat more rapidly, more forcefully, and we went through all those mechanisms in an earlier lecture. You're literally blocking that. So that's why you have beta blockers, and they do what they do. Again, lots of options here. A procedure that you could do for someone who struggles with this is to have an angioplasty and put a stent in, particularly if the problem is going to be plaque buildup and you need to open up those coronary vessels. That would be a procedure that's very effective. If you're treating the patient with drug therapy, you could either go monotherapy or combination therapy. Monotherapy, basically, as the name implies, just giving them a drug. So you may give them a beta blocker, or you may have them on calcium channel blockers, or you just may be treating them with nitrates. So just pick a drug and see if that helps the patient. Or you could do combination therapy. And that's where you're putting a combination of drugs. And so maybe you'll put them on a beta blocker and maybe calcium channel blockers. Now you have to be careful with that, because you can't take, there are some calcium channel blockers that you can give the patient in combination with beta blockers, and there are some calcium channel blockers you can't. So you have to be really careful in terms of how you combo these drugs if you're doing combination therapy. Some people will be on nitrates and calcium channel blockers, and they won't be on the beta blockers. Each of these have their own set of side effects, and so you kind of have to figure out what combination of drugs is going to work best for your patient. Another thing that you have to be attentive to is the patient, most of these patients are older, and so they may have angina pectoris, but they also may have other conditions. And some of these drugs, if you give to treat angina pectoris, may have a less than desirable effect regarding other pathologies that they may be having. So again, you have to look at a patient as a whole to figure out all the things that are going wrong with them, and make sure that you're going to be doing something in terms of the angina pectoris that's not going to exacerbate another pathology. Okay, so I want to return now to just adrenergic receptors in general. We've talked about these before, but you have your alpha-1, alpha-2, beta-1, beta-2, beta-3s. There's also a beta-4 out there I'm not going to talk about. But one point that I want to make also, and I made similar points in other lectures about this, say for example, alpha-1s. there's not just one alpha-1. You have subtypes of alpha-1, and you have subtypes of alpha-2. So again, this is more complicated than even what I'm laying out here, but I'm trying to speak in generalities. So by and large, your alpha-1, alpha-2s, if they are working on smooth muscles, when bound, they're going to cause smooth muscles to contract. If you're looking at your beta receptors, and if they are associated with smooth muscle and they're being bound, then they're going to be causing smooth muscles to relax. So you have a different response on smooth muscles, whether you're talking about alpha receptors or beta receptors. Now again, you can have alpha and beta receptors on other organs, and whatever effect they're going to have is going to be a function of the cell biology of that organ. We've already talked about your beta 1s being associated with cardiomyocytes, and then when the epinephrine or the norepinephrine binds to a beta 1, again, you have your series of events that affect cardiac function. So as far as alpha-1, alpha-2s, most of your receptors on smooth muscle are going to be alpha-1s. I'm not saying that you can't have alpha-2s on smooth muscles. I'm just saying most of the time they're going to be alpha-1s. Alpha-2s very commonly are found on neurons. Am I saying that neurons couldn't have alpha-1s? No. Okay, I'm just saying that alpha-2s tend to be very common in neurons. So I'm not trying to oversimplify to the point of being too specific here. I'm just kind of waving my hands at some general principles. As far as your betas are concerned, most of your beta 1s in your body are going to be associated with cardiac function. And so I've read from different sources. Some people say 75 to 80% of the beta 1 adrenergic receptors in your body are associated with the heart in one way or the other. I'm not saying that you can't have beta 1s in other places. You can. You can have beta 1s on neurons. You can have beta 1s on other organs. I'm just saying that the beta 1s seem to be dominant in heart. If you look at the lungs, and you'll recall this from earlier lectures, the lungs have mostly beta 2 receptors. Okay, and we recall again earlier where if you have epinephrine, norepinephrine binding to the beta 2s, that's going to cause relaxation of smooth muscles, going to open up airways, allowing breathing to occur. Didn't mention beta 3s. Okay, beta 3, not as much known about them, but a lot of literature about their function in bladder. Okay, in terms of smooth muscles there, they also could work in smooth muscles of small intestines. Fair amount of literature on beta 3s on fat metabolism. And they are found in white and brown adipocytes. Adipocytes. Okay, so that's a little something about the beta 3s. We've talked about this before, but you have varying affinities on this. And so, I'm going to speak in generalities, okay? So your norepinephrine tends to prefer alpha receptors over beta receptors. And again, norepinephrine, again, think about it, that is your main workhorse for your sympathetic system. Your sympathetic system is innervating blood vessels for blood flow control. And what did I just say? Most alpha receptors are alpha 1s. And so that kind of makes sense, I suppose. When you get into the norepinephrine where it prefers alpha 1, alpha 2, they're about the same. It does have a much stronger affinity for beta 1 compared to beta 2s. So the norepinephrine, again, as far as affinity, alpha over beta, it's actually the opposite for epinephrine. Epinephrine, a greater affinity for the betas over the alphas. And again, if you'll may recall, this is why if somebody is in anaphylaxis, again, constriction of airways because of a reaction to something, you're not going to give them norepinephrine. You're going to give them epinephrine because you want that epinephrine working on those beta 2s to open up those airways so that the patient can breathe. Another kind of, just affinity type of thing, your beta 1s, norepinephrine, epinephrine, kind of about the same. Your beta 2s, again, strong preference for epinephrine over norepinephrine. Flip with your alpha 1s, norepinephrine over epinephrine, and alpha 2, epinephrine over norepinephrine. So again, just kind of give you a sense of the various affinities of these receptors relative to norepinephrine or epinephrine. Okay, so let's go a little bit more into beta blockers themselves. And again, some of this is repeat, but I'm just trying to make a point here. So your beta blockers, most of, again, your beta 1s are going to be on cardiomyocytes. These are metabotropic receptors. Again, we've already talked about all the things that it does. We've already talked about what it does if it's on a contractile cardiomyocyte versus a non-contractile cardiomyocyte, such as your pacemaker cells. And I'm not going to rehash this, but the end result is if it's a contractile, you're going to end up with greater calcium. Greater calcium means more forceful contraction. If the beta 1s that are associated with your non-contractile cardiomyocytes, they're going to be quickening the pacemaker, and of course that is going to be increasing the cardiac output by increasing heart rate itself. So your beta 1s, again, going to be receiving your sympathetic tone, and so if I'm having a drug and I'm actually blocking that, then again I'm impeding the sympathetic tone, dialing down, making sure the heart doesn't beat too fast, and making sure it doesn't beat too forcefully relative to blood supply. I haven't mentioned this before, but I think the term is obvious. If you're having epinephrine or norepinephrine causing the heart to increase its rate of contraction, that's called a positive chronotropic effect. It's kind of obvious. Of course, I've already talked about positive inotropic effect and increasing force of contraction. So I want to toss that word out there for you, positive chronotropic effect. So again, beta 1 receptor blocking, I'm going to block that sympathetic tone, thereby impeding the heart metabolic rate, slowing the heart down. Beta blockers also are going to affect kidney by reducing renin release. And you may recall when we did kidney, we talked about that. So lowering the renin is going to be reducing blood pressure by 2 mechanisms. One is I'm going to be lowering the extracellular fluid. Why am I lowering the extracellular fluid? Because renin is going to end up causing an increase in angiotensin II. Okay, and so if I'm lowering the renin, I'm lowering angiotensin II, which means then I'm going to be excreting more amount of body fluid, thereby lowering the total extracellular fluid, thereby lowering the blood pressure. Also, angiotensin II is a known vasoconstrictor, so anything that causes me to lower A2 means then I'm also going to be having a lower blood pressure. So again, you're wanting to block all of this. Again, the theme here is just keeping the blood pressure low and making sure that the heart doesn't go beyond its blood supply. Just kind of a side point here, your cardiomyocytes do have some alpha receptors. Okay, they're not that many. Okay, but they are there. Again, I'm not trying to be absolute here. Many of these receptors in many of these areas, but I'm just saying that the dominant one for cardiomyocytes is going to be beta 1s. You can find alpha 1, beta 2 adrenergic receptors on coronary vessels. So your alpha 1 receptors are found on the epicardial coronary vessel. Again, those are the vessels on the outside. And they constrict, and I want to say this very minor, because literature will show you or say that with normal sympathetic tone, the response in terms of vasoconstriction is extremely minor or very minimum, so it just doesn't react to it that much. If you go into the intramuscular regions of the cardiac muscle, they're going to have a lot of beta 1, beta 2 receptors on them, so they would be tending to be responding as vasodilation to a sympathetic tone. Now, I've made this point before, but when it comes to regulating vascular tone, regulating blood supply to an area, yeah, you could have sympathetic tone to the area, but the local metabolic demand, releasing various signals, releasing various chemicals, are going to be affecting vascular flow. So you may have sympathetics coming in wanting to vasoconstrict to a certain level, creating a certain vascular tone, but once that tissue starts working and releasing certain factors, it's going to cause those vessels to vasodilate regardless of the sympathetic input. Another side point here is I just got through telling you, you don't have many alpha-1 receptors, and again, they're not particularly active even in normal sympathetic tone, but there are some people out there that have an abnormally high number of alpha-1 receptors on their coronary vessels. And again, this is an aberration. Those individuals, since they have such a great number of alpha-1 receptors on those epicardial coronary vessels, when they have sympathetic stimulation, it causes those vessels to constrict, and they actually can have angina symptoms. But it's not, again, because they're having obstruction blood flow because of plaques or clots or whatever else. It's just that because of their biology of their heart, they have too many alpha-1 receptors, and so they're going to have angina type of symptoms. So again, local metabolics always are going to dominate over any type of sympathetic input. There are two general categories for beta blockers, selective and non-selective. A selective beta blocker, as the name implies, it's specific for a particular adrenergic receptor. In this case, maybe we would say we want a beta blocker that's acting only on beta 1. Well, then that would be a selective beta blocker. A non-selective beta blocker would have basically equal affinity for multiple beta adrenergic receptors. So they may have an affinity for beta 1 and for beta 2. So if we're talking about, your patient now is starting to have angina, typically you're going to want to start them on, if you want to go beta blocker therapy, you would probably start them on you preferred the selective beta blocker over the non-selective beta blocker and to initially treat their angina. Metoprolol is going to be a common selective beta blocker. Again, it's going to be pretty specific for beta 1. Propranolol is going to be a pretty common one for a non-selective beta blocker. Now, again, you have to be careful with these because, again, recall what type of adrenergic receptors do you have in lung for smooth muscles in airways? Well, those are dominated by beta 2s. Well, what would happen if you gave your patient a non-selective beta blocker, and so now you're like propranolol, and now you're also blocking the effect of beta 2 interaction with norepinephrine or adrenaline? Well, in that case, you're going to have a problem with lungs. So, that being said then, reactive airway disease is considered a relative contraindication for non-selective beta blockers. If your patient is having a problem breathing, if you're having spasms of the smooth muscles of the lungs themselves, the last thing you want to do is to give them something that's going to cause those beta 2s to be blocked. And so that would be a case where you probably wouldn't want to give them a non-selective beta blocker because you're going to exacerbate the problem. So if they've got a history of bronchospasms or whatever, you really want to be careful about giving them beta blockers at all. And if you do give them a beta blocker, make sure it's selective, make sure it's short half-life, and you want to monitor them very closely for adverse effects. So again, things you have to think about in terms of what else is wrong with my patient, where I could have a drug for one particular malady, but again, I have a deleterious effect because of something else going on. So what I want to end this with, just kind of going back over something about affinities. I've talked about this. The effects of drugs, like most drugs, is going to be dose dependent. And so again, for drugs, you have a function of selectivity. And selectivity is going to be how specific is the ligand and the receptor. Is it a very good match? You can have a drug or another ligand that binds to a lot of different things. Well, that would be non-specific. Or you could design a drug, or there's a biological ligand that's very specific to a very docking point, again, and that would be called very selective. So you have to, when you're talking about drugs, is a drug selective or is a drug non-selective? Non-selective means you're getting a lot of interaction and a lot of effects that you don't want. So you'd want your drug to be pretty selective. Then the other thing you think about is affinity. Okay, the affinity is basically, when the drug or the molecule in question binds to the protein, how tight is that bond? And then we talked about this when we talked about oxygen binding to hemoglobin. You had a certain affinity. And of course, what we're talking about here is something that once bound can still be unbound, so it's not permanent. So the affinity is just simply when it does bind, how tight does it bind, which is going to determine then how long that molecule sits in that receptor slot. And if it's got a pretty good affinity, it's going to sit on there longer. It's still going to eventually dislodge, but it'll sit on there longer. So having these two concepts down, let's talk about, say, a selective beta blocker. Well, if I am giving the patient a selective beta blocker, which means that it's going to prefer, say, beta 1 over beta 2, and as long as I'm within a certain dosing, that's the case. But a selective beta blocker can become non-selective if the dose is too high. Because if I have enough of a molecule, even though I might have a low affinity for beta 2, I'm not saying it doesn't have any affinity at all. And so if I saturate the environment with a selective beta blocker, have a lot of them, then it's going to start binding to beta 2 receptors. So this is something you always have to be mindful of when you're looking at drugs. Okay, it has an affinity for this, but not this. They're really assuming at a certain dose, but as you raise the dose, then you start having issues in terms of binding to things that you don't want to bind to. So you may give a selective beta blocker, but if the dose is too high, it may start interacting with the beta 2s in the lungs. And so again, dosing is everything when you're talking about drugs and thinking about affinities. Okay, so that's a wrap for this, and we'll pick up next time.